Hi, everyone. This is Kat Scott, and I'm here today with Marissa Williams, who's a doctor of pharmacy specializing in infectious disease. Her father, Michael Grafasi, was a resident of the Grand Healthcare Rehabilitation and Nursing in Rome from October 2017 till April 2020. We're going to talk today about his experiences there. Unfortunately, Michael passed away in April 2020, and we're going to talk about his experiences there with the Grand leading up to his tragic death. So, Marissa, thank you for joining me today. Marissa, you have an interesting background when it comes to discussing some of this stuff because you are educated and have experience in the healthcare system. So let's talk about that. What is your education background and experience, and just give me the whole kit and caboodle.
Sure. So I'm a pharmacist, and so the degree is Doctor of Pharmacy or PharmD. There are a lot of different types of pharmacists. There's different career paths, and although years and years ago I did spend some time working in retail pharmacy, like the pharmacist you're used to encountering when you fill your prescriptions, there's a lot of jobs that pharmacists do. And prior to the current role I'm in now, I was an infectious disease clinical pharmacist specialist. So what that means is I worked in a hospital and I did 2 years of postgraduate residency in hospital settings with some outpatient as well. So rounded in intensive care units on general medicine wards with infectious disease consult service. And so with that, I specialize in infectious diseases. And when I worked in hospitals, I worked with infectious diseases physicians, residents, fellows, and we would see patients admitted to the hospital that had infections or needed to be evaluated for infections. And my role was to help optimize or make recommendations for the most appropriate treatment for their infections based on available evidence and everything very specific to that patient. And I also help manage in the outpatient setting as well for patients with HIV/AIDS or hepatitis C. So I'm very well versed in both inpatient and outpatient healthcare systems, and is in long-term care as well, although I never provided direct patient care in long-term care, with having a grandmother in one for a long time, and then my dad as well, and just understanding essentially the entire ecosystem of healthcare in the US. I'm very well versed in all of that. I no longer work in direct patient care. I switched about 5 years ago to the pharmaceutical industry, but I still work in infectious diseases within the industry.
Okay, and you are board certified, correct?
Yeah, I'm a board certified pharmacotherapy specialist with added qualifications in infectious diseases.
Wow. Okay, and how long have you worked in the field?
Oh, let's see. I finished my second year of residency in 2009. So over a decade, but I graduated pharmacy school in 2007, and then I had 2 years of on the job training essentially. So what was that, put me at 14-ish years?
Okay. Um, and let's talk a little bit about your dad. Just tell me a little bit about your dad.
So my dad, who was a floor supervisor at Turning Stone Casino for 20 plus years, I remember I was his date to their it's like 20-year anniversary event. He was a person that a lot of people knew very well, loved. You could go anywhere and people would be like, Mike Fossey. And it would sometimes be that he hadn't seen these people in 30 years and still recognized him. I remember as a kid, we went on a short weekend vacation to Niagara Falls. And this was always so embarrassing for me as a kid, right? Everyone knew my dad and be like, oh my gosh. And I remember being in Niagara Falls thinking, well, no one's going to know him here. He's not going to know anyone. And lo and behold, here's someone that he hadn't seen in 30 years. So yeah, everyone knew my dad. Everyone loved my dad. He was very charismatic, very social. Really, really wonderful guy, would give you the shirt off of his back. When I was in residency, actually it started, I noticed it when I was in pharmacy school. When I was in residency, I noticed that when he would walk, like one of his arms wouldn't swing. And things just seemed a little bit off with his movements. And I pointed it out to him, and he went and saw neurologists in Rome. And, just something about it was just very, very off to me. And so I eventually convinced him to come to Albany and to see the neurologist in Albany Medical Center where I was doing my residency. And that was pretty much it. So he was diagnosed with Parkinson's disease shortly after. And he was medicated for it, the standard medications they give for Parkinson's. And he did really well for, let's say, another, almost, really well for probably another 8, 9 years, and then slowly started to decline in terms of his mobility. So when you have Parkinson's disease, it's really hard to initiate movement. So bradykinesia. So you tell your body, okay, walk, but it doesn't quite work that way. So he shuffled his feet a little bit, but with they increase your medication, they change the medications. And so when his medication is at, full efficacy in his body, he could move pretty well. But, it was starting to be more and more difficult. And he always had back problems. And so, without being able to maintain, your posture like you normally can. In Parkinson's, your posture is a little different, and his back problems became too much. And so he retired from Turning Stone Casino. I should know this. I want to say it was in 2016, maybe. So he had been working up until midway through 2016, and still, continued to, he didn't work, but he would go out and about, but it was just becoming more and more challenging. He lived in an apartment that was 2 flights of stairs up. And just over the next couple of years, he had a hospitalization for a blood clot in his lung, which luckily he survived. And, just kind of steady decline in terms of mobility, which when you are of complete sound, mind, it's very difficult to want to take care of yourself and try to stay fit and do everything to help yourself when you know you can't move and this is only going to get worse. Obviously, you don't just randomly have a cure from Parkinson's disease. You continue to decline. So at the end of the year in 2017, it just became really apparent that he could no longer provide care for himself and he needed more help. And with his just Medicare, that wasn't sufficient. So he was able to finally get Medicaid, but he didn't qualify at the time for assisted living facility, which would have been his goal. And then he just really had a decline right after Christmas and went into the hospital for a short visit. And then it was determined that he really needed a lot of rehabilitation. So he then went into a nursing home, which is the Grand Nursing and Rehabilitation in Rome. I believe it was the day after Christmas in 20.
Oh, okay. So it was the day after Christmas in 2017. And what was his experience as a resident in the Grand in Rome?
I think in the beginning, he was really thankful for social interaction. When you can't really get out of your house and you know how things are, people always are going to visit, right? I'm guilty of the same. Oh yeah, we'll come visit it. And just people don't, people are busy too. And so I think he was really thankful he knew people there, of course, because he knows people everywhere. So, he knew someone or was a friend of the family. And so it was, I think, nice from a social perspective at first. And also when you go from having very little help, and my brother helped my dad as well, but he worked a lot. So it was difficult. So when you go from having no help and being alone, when you have some help, especially when you're able to do most things by yourself other than, ambulate as well as you'd like to. It was a pretty nice experience at the beginning. I think he was thankful for that, but things don't stay great for long, especially I think when you're in case of skilled nursing facilities, long-term care facilities, the more you rely on nursing staff for your activities of daily living, the more challenging things become, right? If you could do quite a bit for yourself, obviously, your experience would be different versus someone that couldn't. So there were situations, he was on blood thinners, as I mentioned, he had that blood clot, I think it was in 2016. And so I remember I was traveling for work. I was in Switzerland. I flew a red eye back to the US, but I had to go to another meeting in New Jersey. So I remember I got to my hotel and I turned my phone back on. And I had a voicemail from my brother, Mark, that lives in Rome, saying overnight that my dad fell and hit his head. And so I was obviously panicked because I know he's on a blood thinner and it doesn't take much for you to have a head bleed. And so I said, okay, I'll call the Grand right away. It was already irritated that they had called my brother and not me. But then I thought, well, my phone was off because I was in an airplane, so maybe that was it. But I didn't have any voicemails from them. So I called right away, assuming that they had already had him, evaluated, like a head scan, a CT scan or something like that, to make sure he didn't have a brain bleed. And no. And I'm like, why haven't you sent him for a CT scan of his head? Well, he's okay. And as we did his neurology checks. I'm like, he's on an anticoagulant. He needs to have his head scanned to make sure that he's not bleeding. And it was like this several calls back and forth to the point where it was contentious. And I was like, I don't understand why you are not having him evaluated to make sure he doesn't have a brain bleed. Like, this is just a standard of care. Like, this isn't something like I'm asking for concierge level services here. I mean, it got to the point where I had to say, look, if he declines all of a sudden and it turns out he did have a brain bleed, like, this is not going to end well for you. Like, this is like, I know this is what needs to be done. So it finally was done, and thankfully he didn't have a brain bleed. But if you saw him, I mean, he looked like he got in a fight. He had like a black eye. I mean, he looked horrible. It was really bad. And we're like, this is just
so it wasn't just like a tip over. It was, and with blood thinners, there is bruising, because my mom's on two blood thinners, so there is bruising and stuff. But obviously, this was not just a gentle fall. This was significant enough that you were really concerned that there could have been something, some underlying issues going on that were not being addressed.
Better safe than sorry. And I get people fall, and I know that that's a huge element for nursing homes, and there's quality metrics related to falls, and they take the falling seriously and reporting it, but they didn't act quickly enough, and I shouldn't have had to make so many phone calls and get to the point where I was like almost demanding that they do this. So I'm like, okay, I don't love this situation. And then, and I don't know that I have the sequence of these events correct. It was several years, but there was a situation in which I would call him and talk to him on the phone, and he was like just saying weird things. And I realized that he wasn't quite himself.
And to be clear, he did not have any cognitive deficits from the Parkinson's.
No.
He was still cognitively intact. So this would be an unusual behavior for him.
Right. So, and if you don't spend a lot of time talking to him, maybe you don't know what his usual behavior is. So things were he was getting a little strange, and just like the things he was saying. And I remember, so I was in Rome to visit, and I remembered for Christmas that year, I had sent him mini Tonka moccasins because he couldn't really like tie his shoes very well. His hands didn't, work super well, and he wanted to have his feet warm. So I thought, okay, I'll get him some nice moccasins that have a little bit of grip, because he spent a lot of time in a wheelchair unless he was in therapy working on that. So I sent him that, and then I went to visit him, and in his window, the screen, I could see the top of the mini Tonka like shoebox, and I'm thinking, is there like a hole in his screen and he's trying to prevent bugs from coming, so, like what, this is weird. And so I go over and to look behind to see if there's a hole in the screen, and on the back of this mini Tonka box written is "no" in big letters with like an exclamation point. I'm like, this is bizarre. So I take and I show it to him. I'm like, Dad, what is this? There was no hole in the screen. And he's like, oh, that's so those people stop coming into my room through the window. I'm like, what people are coming into your room through the window? Long story short, he was hallucinating. He was having auditory and visual hallucinations, which is not his baseline.
I don't know what's more disturbing, the idea that someone was maybe coming in the window, or the fact that he was having such real delusions.
And a lot of them apparently, because sometimes he was not able to like explain this to me, but then like with some prodding, it was like a young, like a toddler or young kid version of my younger brother Mark, my dad's son, who was coming into the room and supposedly, according to my dad, peeing on things, like taking things from him, and then Mark's little version of his friends. Like, these were his hallucinations. Then he had told me one time that his dad, my grandpa, was there to visit, and I'm like, okay, this is not right. And so I was trying to work with the Grand, and then remotely, to try to figure out what's going on here. And I don't remember the sequence of events here, but I'll tell you two parts. So I was worried that it was one of his medications, and it was a medication he had been on for years, one of his Parkinson's meds, amantadine. And although not infectious disease, I'm still a pharmacist. And so I still remember things about non-infectious disease drugs and anti-infectives. But I knew that it was possible amantadine could be contributing to this. So I kept asking, is there someone from mental health? Can psychiatry see him? Like, clearly he's hallucinating. And it was very disturbing to him, because sometimes he wouldn't realize that he was hallucinating, and sometimes he was very aware that what he was seeing was not real, and it was unbelievably distressing, as it obviously would be to anybody. And no, we don't have that. And so I don't even remember the sequence of events, but finally I found out that there was like a psychiatry nurse practitioner. Her name was Marilyn Hubbard, I think maybe one of her notes. So I talked to her on the phone, and she agreed to slowly taper my dad's amantadine down, and to lower and lower dose over time. And then that went away. Actually, I think that preceded what I'm going to tell you, or that was after what I'm going to tell you next. But that seemed to fix it. But somewhere in between there, I remember.
So this was going on for a little period of time.
Oh yeah, and when I would talk to the nurses, they'd be like, "No, he's fine." Like, and no one claimed to notice that he was hallucinating. But here I am on a visit, and there's a shoebox top that says no, in the window. Like, I mean, if you're seeing him over and over and you're in person, you have to acknowledge that something was a little off here. So actually, I think that was the end. So sorry, let me back up, because I don't.
Sure. No, it's fine. It's fine.
So I remember talking to him on the phone, and things were just stranger and stranger. And he said he wasn't feeling well. And I remember that something was off, and I don't know if one of the nurses suspected he was having something happened, and he went to the hospital, and he got there, and he was in acute kidney failure from profound dehydration. And I was absolutely beside myself. How could no one know that he wasn't or that he was dehydrated? How come, like, did they check his labs? And so I remember I filed a complaint to New York State as a result of this. And I wish that I could remember the details. And I tried to find a copy of my report, but I was actually in the middle of moving from Virginia to Pennsylvania at the time. So I'm not even sure what I did with any of it, but it did lead to a very serious conversation with the Grand. And I remember my mom went in to see him, even though they had been divorced for years, and he just looked horrific. And maybe there might have been a fall involved there. I forget the exact sequence, but long story short, he was in acute kidney failure. He got a lot of hydration at the hospital. They tuned him up, and he was doing much better, wasn't hallucinating as much. So then the thought was some of this hallucination due to being in kidney failure, and maybe sometimes that can happen. He didn't require dialysis, but he was really, really dehydrated. So I remember I called the nursing home to try to understand his labs. How did no one know this? And then I found out that he did have labs, and his serum creatinine is one of the labs that you would look at to determine kidney function. That was already elevated, and no one seemed to do anything. And then another nurse said, "Oh, well, we encouraged him to drink more fluids." And I'm like, and they were giving him like 750 milliliters. So less than a liter was what they were trying to get him to drink more fluids. But he was really confused at this time. So how do you get someone who's hallucinating, confused, to be like, all right, drink more fluids? And I was like, so you knew this person was dehydrated, and your course of action was drink a little bit more water? That's not standard of care in medicine. You would give them IV fluids. I mean, you call any other medical professional, they would agree with me. So I was really disgusted with all this. Why was no one taking it seriously? How did this happen? And yeah, I got the nursing director, I think her name was Lisa at the time, all these people on the phone, and just no one was like taking me seriously. Like clearly there were things that had happened, and I'm sorry that I don't remember the details here. That someone should have recognized something was going on for a long time. And so it was enough for me to file a complaint with New York State. And I remember I wasn't going, actually, when all of this happened, I was in Denver for a conference, a bone marrow, a hematology bone marrow transplant congress. And I remember like being on the phone with them in my hotel room, and they had like three people from the Grand on the phone with me. I don't know if like the plan was like some type of intimidation tactic, and maybe they didn't realize that I understand medical care and I know very much what I'm talking about. And my job at the not at the time, but previously, like I joke and say, and you know, no disrespect to infectious disease physicians, a lot of them are very close friends that are ID physicians, and they'll agree. The joke was, I get paid to tell doctors what to do in terms of when it comes to recommendations for different anti-infectives. And so, I mean, I work with physicians. I make recommendations to them all the time. Like I work with nurses all the time. It's like these, like I'm a healthcare provider. So these types of conversations aren't intimidating to me. Like this is my job for years. So, you know, they're like got on the phone and like, you know, just you don't know what you're talking about. You know, we did this, we did that. I'm like, no, you didn't. Where's the proof of this? This is, you know, this is what you did. And I just remember being like so disgusted. I finally showed my hand and said, look, it doesn't matter. I filed a complaint with the New York State Department of Health. And then then they wanted to listen. I had asked, I cannot tell you how many times for Dr. Amadon to call me. I wanted to speak to the medical director. I didn't understand how the nurse practitioner that was taking care of my dad could miss any of this. Like, where was everybody? He didn't call me, he didn't call me, he didn't call me. So finally, after I said I filed this complaint, then, oh, we'll have him call you. And so I think that was their intimidation tactic 2.0. So I remember I was walking into this conference center. I'm sorry, it wasn't Denver, it was Salt Lake City. So walking in Salt Lake City, and I had my colleague with me, and I'm like, I'm sorry, this is the physician. I need to take this call. And I think he was trying, you know, to act like he knew a lot more than me. And okay, he's a physician, so I would hope that he knows more than me with when it comes to diagnostics, but I'm obviously not a layperson that knows nothing. And so I was telling him it was very clear to me that my dad was dehydrated. And he's like, well, you don't know that. I said, I had saw his labs. He had prerenal azotemia. Like don't BS me. I know that my dad was dehydrated. The nephrology consult from the hospital agreed with me that my dad was dehydrated. Like I'm not making these things up. And then I remember him saying, well, between you and I, your dad really should have received IV fluids. And I remember saying, between you and I, like a monkey would know that my dad needed IV fluids. Like this is not like, you know, specialized medicine. And so I just remember thinking like, this is ridiculous. And so I filed a complaint. I remember I was in the midst of moving when the New York State Department of Health representative called me. They were, you know, getting some more information from me, like we're taking this very serious. They were there for a while investigating it. She had like checked in with me. And it sounded very much like, how could you not find evidence that this is what happened? And, you know, she was, you know, really concerned with the things that I was telling her. And then months and months went by. And then I just got this like random letter that was like, we didn't find anything. And I'm thinking, how could you not find anything? Like, look, these are lab values. Go look at the, you know, like look at his admission notes. And it took until years later for me to realize that the documentation at the Grand isn't going to be documentation that essentially incriminates them, right? They're just going to document the little bit of information they need to document. And how do you expect someone from the Department of Health to come in and piece all of these things together? They didn't have the notes from Rome Hospital and the nephrology consult that said that my dad was profoundly dehydrated. So I was really disappointed, but it is what it is. I know what I saw. I know what the hospital said. I know what Dr. Amadon said. And so this kind of began this like, all right, Marissa, you really need to stay on top of this. And anytime, you know, my dad wasn't much like, he didn't really complain. He would call me if something was wrong. Like a lot of times he tried to handle things himself because he was, except for in this case of hallucination, otherwise, you know, cognitively intact and alert and oriented times 3 and knew what was going on. So only if he felt he was getting nowhere would he kind of, you know, call me to have me involved, because he always felt like he was bothering me. And I would always say, you're not bothering me. But he also knew that this stuff was going to like really, really, you know, get me going. So then I think it was then after that, a little bit more hallucinations, they tapered. I got this nurse practitioner work with me to taper this medication off, and he was pretty much good after that. So nothing crazy after that. Well, then became with his Parkinson's disease, he had a little bit of neurogenic bladder, so he didn't have full emptying of his bladder, and he would need catheters or to be intermittent cathed sometimes. Then he started getting all these UTIs and seeing a urologist quite a bit. And they wouldn't do his intermittent catheterization for him and wouldn't help him, and he was trying to do it himself, and it just wasn't working out. He'd be in pain with all this urinary retention, and this is like perfect setup to have urinary tract infections.
Now, just to be clear, this is a skilled nursing facility.
Yeah.
So, I mean, assisting him with this is pretty much their job.
Yeah, you think, actually, I did have that addressed. I had to have the urologist write a note, write a medical order to assist my dad with his self-caths. And then and only then was it done. But when he was saying, I need to do it, no one was helping him. So,
and if anyone out there, catheterization is not a pleasant experience.
No.
Nobody volunteers for this.
Yeah.
This is not a fun thing, because my mother has some issues, and anytime we have to test her for a UTI, they have to go in for a clean catch. So, sometimes I really want to make sure that it's worth it for her, because it's not pleasant. It's not fun. So for your dad, it would be, and especially Parkinson's, he has mobility issues. For him to self-cath would be difficult to begin with, and there's a pain issue. So yes, he's in a nursing facility. They should have been assisting him without a doctor's order.
Right. One would think. I mean, he had an order to self-cath. He had the equipment. It's not like he was, getting straws from the
right. It wasn't like he was DIYing it.
Yeah. And obviously you don't want to have an indwelling Foley catheter in someone if they don't need one. You want to try to avoid that, because then that sets them up for recurrent urinary tract infections. So
right. I mean, and for people out there who don't understand that, that's a great explanation as to why he was doing it, or they were doing it, and he didn't have something permanently in there. Right. Because UTIs can kill people.
Absolutely.
I think, a lot of us that are young and healthy who have ever experienced one, while they are not pleasant, do not fear for our lives. But in people who are elderly or disabled, a UTI can be fatal. And we recently saw this with Tanya Roberts. 65 years old, was found non-responsive and ended up dying from what ended up basically being a UTI. So these are important issues for those people who don't know elder care and all that. I just wanted to make sure people understand this, because, I mean, we're young and healthy, so for us, it's not a big deal. But
even young and healthy people, so
have to be careful.
Any site of infection can lead to something called sepsis, which is inflammatory response as a result of an infection. So there's a lot of different things, and it's a really perfect segue for what I'm going to share. If a UTI is undiagnosed and so therefore not treated, or if it's caused by a bacteria that is resistant to treatment by the common antibiotics you normally would think would work for these bacteria, then you think you're treating it, but you're actually not. And so what happens is, if you leave this untreated, the bacteria, can go in your kidneys, and it can go into your blood. And that's typically when people die from septic shock as a result of, with the source being a urinary tract infection. That's what happened. So it went into their bloodstream, essentially. It caused a severe inflammatory response syndrome. Your kidneys shut down. You go into multi-system organ failure. And if sometimes it's just a little bit too late in that cascade to essentially recover. If you get to the point of being in septic shock, where now your blood pressure is not responding, to fluids, you essentially have a 50% chance of mortality. So yeah, even in a simple urinary tract infection, it needs to be treated. So I remember this was March of, I'm trying to think when my baby was born, March of 2019. I went to visit my dad. I was pregnant. He didn't know. I hadn't told anyone yet. I wanted to go tell my family back home as a surprise. And so I went out. My husband stayed behind because he wanted to paint in the house and didn't want me to paint. Didn't want to paint while I was home. So I brought my son up, who was 3 and change at the time. And we came to visit, and he had a little t-shirt on that said like Big Brother. And so that was part of the surprise. And so actually my sister-in-law and my brother that live in Syracuse, there was kind of a little overlap when we went to visit. So we go in, say hi, tell them the news. Everyone's so excited. And I remember my dad talking about not feeling very good. He had a fever of the, few days before. And I'm like, why am I hearing of this? Oh, no, it's okay. I have a UTI. I'm getting shots in my legs. And I'm like, they're giving you intramuscular antibiotic. Like what? Okay. Like I need to know what's going on here. And so I went up to the nurse's station to get information. And just, I didn't say this up front. I want to say not everyone that works in any nursing home or this nursing home in particular is a bad actor. There are truly wonderful people there that want to help people, and that's why they're there. I understand some people have bad days, especially if you're in a situation where you don't have enough staff and you have too many people to take care of, or, we're all human beings. We have things in our life that may contribute to our overall mood on the day. But it was very clear that my question asking was irritating, and me wanting to, you get like, oh, this is a situation. No. Pull out his chart. I want to see everything. And no one wanted to deal with that. I get it. But I was not going to be satisfied until I got an answer. So, and I'm actually looking for the paperwork because I thought I had it super handy. Of course, I moved things around, so who knows where I put it now. But anyway, so I find out that he's getting an antibiotic called gentamicin, and I want to know what bacteria he has in his urine. So like, oh, it took a while. They then show me the culture and sensitivity report from his urinary tract infection, and he had multi-drug resistant Klebsiella pneumonia producing carbapenemases. So that is a lot of words to say. This is a bacteria that is resistant to many antibiotics, most really that you normally use to treat urinary tract infections. And the antibiotic he was receiving actually was sensitive, so it should have been active to treat his UTI. Unfortunately, the dose was 40 milligrams, which is the dosing, and I'm going to pull my calculator out actually really quick and look this up. So my dad's weight at the time was probably 250 pounds divided by 2.2. So my dad weighed 113 kilograms. And so his dose should have been 300 milligrams per kilogram. And so he should have been getting, we'll round up, 350 milligrams once a day of gentamicin, and he was getting 40 milligrams. So 40 milligrams would have been enough for a 30-pound kid. So that would have been the right dose to treat a UTI in my 3.5-year-old.
And since this is your area of expertise, what happens when you underdose for a bacteria like that?
A couple of things. So first, you're not treating the infection. And also and this can happen quickly, but overall antibiotic pressure over a period of time is more likely what drives resistance. But you essentially, if you think of a whole bunch of bacteria growing on an agar plate, right? You're in microbiology and you have all these little colonies. Some of them might have be more sensitive to concentrations of an antibiotic than others. And so let's say that there was some of them were kind of weak. And so you give this antibiotic, but at too low of a dose, and it's killing off the little weak bacteria, and it's leaving the harder to treat guys behind. And so those are what are going to multiply. And so now you're essentially driving up what's called the MIC, the minimum inhibitory concentration of this bacteria with selective pressure from an antibiotic. So that would be a bad thing in general, and that's bad. And that's why we have antibiotic resistance, but also because the unnecessary use of antibiotics and a lot of things. But in a situation where you have a bacteria that is very resistant to most antibiotics, and this one is still sensitive, if you're underdosing the antibiotic, what's just going to happen is over time, that antibiotic's not going to work for that bacteria either, because you're just going to drive up the concentration needed to kill this bacteria. But at the same time, you're actively not treating this infection. So on paper, you may think, oh, look, this paper says sensitive to gentamicin. He's getting gentamicin. But for all intents and purposes, he might as well have not been getting gentamicin because it wasn't enough to kill the bacteria. So I know this. I mean, this is what I did for years in a hospital. Like I have an infectious disease physician friend that used to call me so gentamicin is a type of aminoglycoside, but he would call me like the gentamicin whisperer, because I'm really good at dosing these types of drugs. This is what I do. It's concentration dependent kinetics. There's math involved. It's pretty it's pretty straightforward, but a lot of people aren't good at it at the same time. So long story
So
short,
when you see this though, as a daughter, this has to have an emotional response.
I was furious. And so at first I'm thinking, okay, I'm irritated. Um, but also maybe it's just someone didn't know better, right? So in all fairness, infectious diseases is tricky. It's one of those things where
Right. You're
a lot
not
of people get
expecting the
infections, but not everyone has to be experts in treating them, especially when it comes to multi-drug resistant, bacteria. And so I'm like, okay, this is not good. And also no one told me that he had a UTI. And also he has a multi-drug resistant gram-negative bacteria that he's clearly colonized with, which is causing this infection. And he is not on contact isolation. He has a roommate. I walked freely into his room. The nurses walked freely into his room. No one's gloved and gowned. They're going into these other rooms. So this is an infection control big no-no. So that infection control part doesn't impact my dad, but it impacts everyone around him. And since this is what I do for a living, I'm also now concerned about everybody else. And so,
right. So I just want to make this clear. So by not taking the necessary precautions, they could have been spreading this bacteria, which is resistant to many antibiotics, to other residents of their nursing home, possibly even to themselves. And that to me is appalling. My mother has VRE, which
yeah,
I'm sure you can say. I cannot.
resistant enterococcus.
Yes. My mother is in a private room.
Mhm.
She is a Medicaid patient, which in nursing homes she would normally have a roommate, because in New York State, when you have a Medicaid patient, you do not have a private room. But my mother needs to be in a private room for infectious disease control. And that's why she's in a private room for infectious disease control, unless there is another resident who also has VRE,
Right.
which they do not have. So that's how I have a limited knowledge of this. We talked a little bit before we started this interview that I'm genuinely shocked to hear this. This is
So the first thing I do is I tell the nurse, like, there's a lot of things going on here that are not correct. Can you please, and it was a weekend. And by the way, I was pregnant. And so, in general, I was not having it. Like,
right, right, right.
not having it. So, so it was a weekend and I say, can you please call the nurse practitioner? Cause I have a copy of it and I'm so mad at myself. And I don't want to sit here and fumble through papers. And what I mean by papers, I mean, oh, I found it. I lifted these up and I found it. And I actually have some of my own notes on this, but this is the culture and sensitivity report. I'm not making this up. I know that the Grand likes to say that things aren't true. And so, yeah, so I was there in the beginning of March. This is from February 28th, and it says gentamicin 40 milligrams intramuscular QD, which means once daily times 5 days, CBC, CMP. So they wanted to order, check his white blood cell count essentially, and a CMP is, so complete blood count, CMP, comprehensive metabolic panel. That's to check a lot of things, but including kidney function, because the antibiotic he's receiving is not good for your kidneys. So it can be nephrotoxic. But
And this was after he had already had that dehydration period where his kidneys have taken a hit.
Oh yeah, absolutely. Yeah.
So
And,
this is important.
It's important, right? And so it's important to make sure that this drug is, I used to say this in the hospital all the time. If you're going to use a drug that can potentially worsen someone's kidneys function, or make it so bad so that they require dialysis, you better use it correctly. So it's this situation where it's underdosed, and so you're not treating his infection because it's the wrong dose, and really essentially all you're doing is exposing him to toxicity with absolutely no benefit. So
right, it's the whole physician do no harm,
right,
kind of philosophy of medicine.
And I get it. If you were to look this up in whatever reference they use, it'll probably say 1 milligram per kilogram every 8 hours. So that would still be an underdose for my dad. But the problem is there's different dosing for infections for different types of bacteria. So if my dad had VRE in his bloodstream, and it caused him a heart infection, and I was adding an aminoglycoside on to his other antibiotic, then you, that's a synergy situation, you give a lower dose. But in the treatment of a gram-negative rod in the urine, 3 mg per kg at the absolute minimum dose. So anyway, so they send this to me, and gentamicin's underlined, and I have all of this here. So I see that it's signed by, and it says, have Randy see an AM. He was the nurse practitioner at the time, per Dr. Amadon. So first, call Dr. Amadon. Oh, well, he doesn't work on the weekends. We'll call Randy. Oh, well, he's not going to return your call. I'm like, this wasn't a, please have him call me if he's not busy. I need to speak to him. You're treating this inappropriately. And so, okay, I'll call him. So I'm waiting. I'm talking to my dad. At this point in time, my brother and my sister-in-law take my 3-year-old to my mom's house because I've now been here for like an hour plus, and I'm getting more and more irritated. No one's called. No one's returning calls. I go back out. Did he call back yet? He's not going to talk to you. And I'm like, I'm not sure that's how this works. Okay. And so then I said, look, I will stand here at this nurse's station for the next 5 hours until I get this resolved. And then, I felt bad because now the nurse is the person I'm directing my disgust towards, and it's really not her fault. I recognize that. And so I said, look, I know this isn't your fault, but I need you to do this communication. Well, this nurse practitioner is not going to call me back. And to be clear, I had never had, other than that one time when I filed the complaint with New York State and Dr. Amadon himself called me, never did I ever have another nurse practitioner or physician return a single one of my requests for phone calls. So anyway, I waited, and I'm like, okay, this is like, nothing's going to get done here. So I called my dad's urology office because I know he sees a urologist, and I thought maybe I can get them to do the right thing. So my dad's urologist was not working the weekend, but there's an on-call service. So I get a urologist within that office on the phone. I explain to him who I am. So he doesn't know, it's not like this urologist has a history with me. I say, my name is Marissa Williams. I'm the daughter of this patient. I specialize in infectious diseases. I promise you, I know very much so what I'm talking about. I wouldn't be making this phone call if I didn't. I have the culture and sensitivity report. This is the situation. I'm sorry, let me back up. There's importance to the story. So on the background in my handwriting is some more notes about culture and sensitivity. So I got the information from the lab where my dad's culture was sent to see if they would do additional susceptibility testing for an antibiotic that wouldn't be toxic and is actually used for this infection. So
basically you are doing what you are professionally trained to do.
But shouldn't have to do as a daughter, and what they should have been doing. Yes, exactly.
You're trying to find the best way to treat your father because he's not being treated correctly. Right. And no one else is picking up on this.
No, apparently
they're fighting you. They're fighting you.
Yeah, and as if I'm somehow the jerk in this situation. It's honestly mind-boggling. So I call and I say, what bacteria had he had in previous UTIs? And can you test this other antibiotic? Yes, we can get that tested. And so, but this other antibiotic is IV only. So now keep in mind, the drug my dad's getting is intramuscular. At the dose he needed, it needed to be given intravenously. And so I'm like, I just don't why would the doctor not just order this other antibiotic that is the drug of choice that you would use to treat this type of infection? Well, it's IV. Okay, so what's the problem? Well, the pharmacy we use it's a couple hours away by the time you order. And I'm like, so do the right thing. Why are you not giving, you have access to gentamicin. Why are you not giving that IV? We don't have anyone here to place an IV line. I'm like, okay, I'm sorry, let me get this straight. You don't have an RN on staff that can place a peripheral IV. No. Well, where is this, the United States? Where are we? What do you mean you don't have a nurse on site to place an IV? It's just appalling to me. Wait, no, so no one places IVs here? Is that, so now I'm thinking that's why my dad didn't get IV hydration back when he was dehydrated because no one was here to place an IV. Okay, so you're not using IV antibiotics, no one's here to place an IV. Brilliant. So long story short, because I can't get this IV antibiotic and there's no one here to place an IV, I now call this nephrologist or a urologist, I'm sorry, who calls me back. I explain the situation. He's like, okay, I agree with you. I agree with what you're saying. What do you need me to do? I said, I need you to call the nursing home and I need you to order gentamicin at 350 milligrams IV every 24 hours. And he's like, okay, I'll call now. So he called, he made the order. And actually after, when I finally got my dad's medical records just a few months back, I read in the notes this encounter, and you can even tell the language in the notes that they're very irritated that I had that done, because there was like documentation that the nurse practitioner had to essentially agree with the order from the urologist, which they did. It's like, don't you dare fight me on this because I'm right. Evidence-based medicine says I'm right and you don't have a leg to stand on. So anyway, that's how I got my dad to get the right antibiotic. I had to page an on-call service urologist to look at my dad's medical records, listen to my professional recommendation. For the record, I am still licensed as a pharmacist in New York State. So to listen to me and take my recommendation, because not a single person at the nursing home would even return my phone call. And again, I'm the jerk here, but then they still didn't give him an IV and they gave him multiple shots, intramuscular injections in his leg. Thankfully.
Wait, I'm sorry. So even after you went through all of that, they didn't do the IV?
No, they give it to him IM in several different injections.
Even though they had a doctor's order from a specialist, a urologist.
They changed the order to make it intramuscular because they didn't have a way to place IV or to make a way to make up. So when you give intramuscular, it's a small volume, right? And you essentially give undiluted drug. When you give something IV, you dilute it in usually normal saline, sometimes D5W. So anyway, they didn't have a way to even make up a mini bag to make up a dilution of gentamicin. So they're giving it in multiple shots. Thankfully, my dad has enough neuralgia, like basically lack of feeling, that it's not super painful for him to get all these injections because he's a little numb. But can you imagine if you were, I don't know if you've ever had an antibiotic shot or any shot, but can you imagine several times a day getting multiple injections to get the right dose? So just appalling. So this
I actually have, and I can say, because I had a terrible time with asthma in my 20s. A lot of antibiotic injections and urgent care and emergency rooms to get me started, and also prednisone, which is not a fun.
No, none of that is fun.
To get. So I could not imagine doing it multiple times a day. Usually I would be in the emergency room or urgent care, and it would be just a shot to get me started.
Right.
So yeah, I can't imagine.
In the meantime, I then say to the nurse there, my dad needs to be on contact isolation. Like, make this happen. Oh, well, I'll talk to him. And I'm like, what do you mean? So then they supposedly talked to the nurse practitioner about this. And the message they sent back to me was like, oh, they don't really think that, this is necessary for him. I'm like, are you dense? Like, this is not for my dad. This is for everybody else. So he never even got put on contact isolation.
How is that even, there's a certain standard.
They should have an infection control plan that outlines all of that. I believe they do now, but they certainly didn't at the time, or they didn't understand what sensitivity patterns suggestive of CRE, carbapenem-resistant Enterobacteriaceae, meant. That means it's, and if you look at there was only one drug on this entire report that was sensitive, and that was gentamicin. So this starts the saga of urinary tract infections. And so finally he got better from that, thankfully. And then, oh, Marissa, I got a UTI again. And so sometimes, and every time I would call and I would get the culture and sensitivity, because typically once you're colonized with a resistant bacteria like that, it's often a cause of urinary tract infections. Again, luckily this particular one wasn't, thankfully, but he did have different, a lot of times, another Klebsiella pneumoniae that wasn't carbapenem resistant. He had a lot of Proteus, rhabdosis, and UTI, causing UTIs. that were extended spectrum beta lactamase producers, or ESBLs. So not quite as bad as a CRE alphabet soup, but still pretty darn bad, because usually you want to treat a UTI with an oral antibiotic, right? That's the
Right.
easiest way. But the problem is with an ESBL, typically a lot of the oral options are also are ineffective. But sometimes, an ESBL would not mean, a lot of people probably heard of like Cipro, right? How many times has someone
Right.
had Cipro for a UTI? In this situation, my dad's Cipro was still sensitive because an ESBL wouldn't make Cipro not work. But typically when you have a lot of resistance mutations, it's not just one of them. There's usually a lot of resistance. So anyway, I had to stay on top of these things. So he would get a UTI, I'd call, get the culture and sensitivity. This is what I'm getting. Okay, fine. So not that long ago, it would have been, it might have been I don't remember if it was the very end of 2019 or the beginning of 2020. But my dad called and he's like, I have a UTI again. I'm not feeling well. And I had talked to a nurse who was super lovely. And she was like, your dad's just not himself. Like, I used to work in a stroke unit. Like, I'm really worried. I'm like, okay, like, please send him to the hospital. Although I don't think he's having a stroke. Like, I know that he's been having UTIs. And so maybe he's having some confusion, because a lot of times elderly patients, when they have urinary tract infections, they have some altered mental status and confusion. It's not uncommon. So she sends him to the ER. And I called the ER and follow up, and I'm talking to the nurse who I actually happen to know, and I'm like, hey, listen, my dad has a history of resistant urinary tract infections. All of the microbiology is done at St. Elizabeth's, but if I can please make a recommendation to the ER physician. So he knows that I know what I'm talking about, took me seriously. I got on the phone with the emergency physician to find out that my dad had been getting intramuscular ceftriaxone, which sometimes can be a good antibiotic to treat UTIs, but knowing that I know that he had a history of ESBL, or extended spectrum beta lactamase producing bacteria, I knew that ceftriaxone is not going to work. And so I tell this to the ER physician, and he's like, okay, this makes a lot of sense. I said, look, here's the dates of when he had this bacteria in the past. It was resistant to ceftriaxone. Can you please give him ertapenem, 1 gram once a day? IV, please. Stop because he's going to be admitted. He's sick enough to be admitted.
Okay.
And he said, absolutely no problem. That makes a lot of sense. Thank you so much for your help. And I'm like, wow, was that hard? No. So he's admitted. That's exactly what he had. He had an ESBL proteus, again, sensitive to ertapenem, because I know what I'm talking about. And this is exactly what the situation was. They sent him back to the Grand after a few days and to finish his ertapenem. And you can give ertapenem intramuscular. And because, again, there's no one there, when you get a peripheral IV line, you usually need to be changed every 3 days. And since he didn't need antibiotics for that much longer, okay, fine. So he finished the rest of that, getting intramuscular ertapenem. Fine. Okay. So a couple months go by and he has a UTI again, and he calls me and I was like, what are they giving you? He's like, oh, those shots on my leg that starts with a C again. And it's like, did we not learn this from a couple months ago? With the bacteria that he most likely is colonized with causing this infection, that drug's not going to work. So I get the same nurse on the phone that I had helped with in the past. She's like, okay, well, I'll pass you on to the nursing supervisor. Her name is Sarah. She's so helpful. And I'm like, Sarah, please just call the nurse practitioner and tell him that my dad needs ertapenem. Pull up the last notes. Like, okay, like make sure you get culture and sensitivity, because he had a history of a bacteria in which ertapenem actually wouldn't work. But most recently it was this. So this is likely the cause. And after several phone calls on her part and my checking it back and forth, they finally got it done. But had it not, he would have been getting the same antibiotic that was just resistant a few months ago. This is not hard. So anyway, that was good. And Sarah was really helpful.